Okay, in the interest of everybody's time, I think I'll go ahead and get started. My name is Elaine Adams. I'm speaking to you as a rheumatologist. I'm a professor of medicine at Loyola, and I'm going to talk about one of my favorite topics because it's just fascinating, and that's the topic of gout. I'm going to apologize in advance because while I've done many lectures, I have not done a Zoom lecture yet. So if we have technical challenges with the able assistance of Dr. Bial, we'll try to resolve it as quickly as possible. I'd also ask you to save any questions to the end, and if you could type them in, I'll try to answer all your questions via the chat box. Okay, so you'd probably recognize this picture as someone with gout. While he doesn't exactly look like our patients here in the CLC, the trappings of rich food and alcohol and overweight are really typical of a patient with gout. Now, gout is an old disease. It's been present at least as long as Egyptian mummies, who've been found to have findings in their bones that would be very suspicious for a tophaceous gout. It's also been known for several hundred years, at least, that there was a relationship between uric acid and gout. But on the basis of really mixed animal studies in which uric acid didn't cause much inflammation when injected in animals, it really wasn't clear until more recently that uric acid was the cause of gout. Now, for those interested in research, you can get a lot accomplished with a very small study. And what I'm showing you here is a study done by a rather famous rheumatologist, Dr. McCarty, from the Medical College of Wisconsin. In 1962, he published an article in the Lancet, in which both he and his fellow, Dr. Fairs, injected their own knees with sodium urate crystals. And like a good scientist, they injected the opposite knee with saline as a control. Well, you can predict what happened. They describe, and it's a really interesting article to read, that within 2 hours they had severe crushing pain. They described systemic reactions with diaphoresis and bradycardia and syncope. And 4 hours after the injection, they were prostrated owing to excruciating pain. The next line in the article states they had intended to continue rounds all afternoon, but were unable to do so, which we might be able to relate to. So on the basis of this study with an N of 2, and if it was repeated, no one ever published it, it became quite clear that in fact uric acid was the cause of gout. Now, gout in many ways is an understudied disease given its frequency. And we know that gout has been increasing really quite dramatically since the 60s and 70s. Here's a listing of just a number of studies from around the world showing a 2 to 3-fold increase in the incidence of gout over approximately 20 years. Now, why would that be? Why should we see more gout? I bet you can predict some of these, predict some of the reasons. Main reason underlying cause of gout is genetic. We don't have any reason to think that has changed, but we do know the population is aging. I realize I'm speaking to the experts on this on the call. Male population unchanged, but also acquired factors that increase the risk of gout, also increasing in the world population, certainly in the US population. And these include obesity, alcohol, renal failure, hypertension, hyperinsulinemia, and the use of low-dose aspirin and diuretics. And finally, lead as a risk factor, likely less important now. Low-dose aspirin actually inhibits the excretion of uric acid. So if you think back, It's really in the 80s and 70s when we began to recognize the effect of low-dose aspirin on reducing cardiovascular risk. So one could argue that it was absolutely predictable as we begin to put the entire world's male adult population on aspirin almost, that we would see more gout because of its effect on the urinary excretion. One of the fascinating things about gout is that it is really a human disease. Most fish, amphibians, birds, and most mammals have an enzyme called uricase that breaks down uric acid into a soluble entity called allantoin. Now, allantoin is freely excreted in the kidneys, doesn't deposit in any tissue, and so really only humans develop gout. So key question might be, well, why don't humans have uricase? It turns out that they do. When the human genome was completely described, we discovered that humans, in fact, do have the ability to make uricase. However, there are multiple mutations on different chromosomes that actively inhibit the activation of uricase. Now, this usually implies a very strong evolutionary advantage, and that remains a bit of a mystery as to what that might be. A couple theories. One is the antioxidant theory that urate is an antioxidant. And that always seems a little gray and fuzzy. What exactly does that mean, and how does that relate to a survival advantage? But that's one theory why humans would have inhibited their uricase. The other is that uric acid in its handling in the kidney, which we'll talk about in just a minute, is also reabsorbs sodium. And so one theory is that sodium absorption was an evolutionary advantage as humans began to assume an upright posture, decreased postural hypotension, and that this may have been the advantage for inhibiting uricase. Right now, this mystery remains unsolved, but it's fascinating nonetheless. Okay, just a word about uric acid. You probably all remember this. This is the end product of purine nucleotide degradation. Anytime a cell dies, you're making uric acid. You're all making it right now as we speak. Uric acid has a theoretical limit of solubility of 6.8 at the pH of human serum. So as you can see, that's very close to the range that we see in humans. And it doesn't take much for the level of uric acid to exceed that theoretical limit of solubility, making gout adding to its commonality in the population. Well, if we're making uric acid, how do we get rid of it? About a third of it is excreted in the gastrointestinal tract. That occurs initially, was thought to be passive. There may be an active component there as well. And once this gets into the GI tract, it's completely degraded by intestinal bacteria because, of course, they have uricase, even though we don't. Unfortunately, the GI tract is pretty much maxed out at baseline, so we don't have much room to increase that when individuals develop hyperuricemia. So the majority of our uric acid is excreted in the kidneys by renal excretion in a really fascinating mechanism. And in this next slide, I'm going to show you how this works. Now, you probably all remember this from school, but here's uric acid being filtered at the glomerulus, and nearly 100% of uric acid is filtered. One would think that might be the end of the story, but in fact, almost all of it is reabsorbed in the proximal tubule. About half of it is secreted again, with most of that being reabsorbed again, and the net excretion about 10% of the original filtered load. This process across the proximal tubule is an active energy consuming process. Again, more evidence that there is an evolutionary reason to spend all this energy moving your uric acid across the tubules. A little bit about this information came with the discovery of a urate transport, anion transporter. This was really discovered less than 20 years ago. The first one discovered is called Urat1, and here we've got the tubule, here's the cell, and you can see that we can get rid of all kinds of negative anions that we don't want in exchange for urate. And along with that goes sodium, and the urate is then reabsorbed into the back into the bloodstream. So lots of work still being done looking at this in terms of the genetics and how that relates to the etiology of hyperuricemia in patients with gout. Anion co-transporters, there are a number of those that are specific for others. These are specific for uric acid, and so likely important in what in our understanding of how urate is retained in humans. Okay, now I know you all see lots of patients with gout, and we'll talk in a minute about the clinical aspects of gout, but we also have to talk about the causes of hyperuricemia. And I would ask you, whenever you see somebody you're thinking about, begin to think about, why do they have hyperuricemia, and is there something I can do about that or should do about it? Well, the most common cause is decreased renal clearance. That's responsible for about 85% of patients who actually have hyperuricemia. Most of those patients have a primary genetically inherited defect. Very few have been actually identified to be a URAT mutation, but it's very likely that there are, with additional study, more will be identified. There are also lots of secondary causes of decreased renal clearance, and these often go hand in hand with a primary decreased clearance, gout precipitated then by secondary causes. And I suspect you're familiar with most of these. Renal failure, even a little bit of renal failure, decreases urate excretion. Volume depletion, whether that's dehydration, diuretics, can decrease renal clearance. Obesity is very interesting in that it is strongly associated with gout. Now, it's been shown to decrease renal clearance. It causes increased production. And so there are multiple ways in which obesity affects your level of uric acid. Acidosis from any cause, not surprisingly, if we think about how urate is handled in the kidneys, increases serum uric acid. And then, of course, there are drugs, some of which we use commonly, diuretics. I mentioned low-dose salicylates, and alcohol, if you think of that as a drug, all cause hyperuricemia by decreasing renal excretion. The other way is to make too much uric acid. Now, there are inherited defects of purine synthesis. This is in a minority, probably about 10% of patients who have gout will actually have one of these defects. There's virtually very little value in trying to identify these defects unless you have a study, or unless the individual's identified at a very young pediatric age. I sometimes think these are mostly valuable for testing purposes, although if there are residents and students out there, these questions usually don't appear on the internal medicine boards. Geriatric fellows let me know if they appear on the geriatric boards, but I suspect not. More common causes that you may see of overproduction, if you think about it, it's anytime you have cell death. So malignancy, rapidly growing malignancies, particularly leukemias, lymphoproliferative diseases, or patients who are being treated with chemotherapy can develop very severe hyperuricemia as a result of cell death. Hemolysis, we don't think of that as cell death, but in fact it is. The red cells had a nucleus, and so rapid hemolysis can result in hyperuricemia. Obesity shows up on the list as well. We don't understand why obesity should lead to overproduction of uric acid, but that's been well documented. And a few other things, psoriasis. Psoriasis, all those flakes that are being sloughed off the skin, each of those represents cell death. And so patients with psoriasis frequently have hyperuricemia. The clinical manifestations of psoriatic arthritis, particularly the dactylitis, can actually mimic gout. So this is important to recognize that these two diseases can sometimes be clinically difficult to distinguish from each other. Tissue hypoxia. You might see in geriatrics the patient who fell down, can't get up until their family member comes 24 hours later, and so has extensive tissue and muscle necrosis. These patients will have extensive cell death and may have profound hyperuricemia, worth thinking about and looking at when you see those patients. And then, of course, dietary factors. The dietary factors we'll talk a little bit about the end, but ethanol, red meat, and high fructose corn syrup are big factors in the production of hyperuricemia. Before I go to pictures of gout and tophi and the treatment of acute gout, I have to just mention the relationship between hyperuricemia and cardiovascular disease. Hyperuricemia is an independent predictor of hypertension and coronary artery disease in many studies over the course of many years. In the next bullet here, I point out just two. These are more than almost 45 years apart, which show hyperuricemia increases the risk for cardiovascular disease 3 to 5 times. That is a huge increase in risk. So why aren't we more excited about this? Why aren't we doing something about it? Well, the problem is the confounding risk factors. So hypertension, renal disease, obesity, insulin resistance are frequently present in patients who have hyperuricemia. And the epidemiologic studies, observational studies, retrospective studies have simply not been able to effectively dissect out the relative effects of these co-founding risk factors. So based on a review study in the last year published looking at really the world's literature, the question still remains open whether hyperuricemia is truly an independent predictor of cardiovascular disease. So there is, in essence, no evidence to date that a reduction in serum uric acid reduces cardiovascular risk. Now, in this last sentence, I'd like to say the emphasis here is no evidence. The study that really needs to be done is a randomized trial of a very large population of patients matched for confounding risk factors, some treated with uric acid lowering drugs and some not. And to date, that study really has not been done. So no indication right now to treat simply for the basis of cardiovascular disease prevention, although the hypothesis remains out there to be tested. Okay, let's talk about something you're familiar with. I'm sure everybody on the call here has seen this. Here's a patient who might be in the CLC, might be in clinic, might be in the emergency room. And the patient calls with a red, hot, swollen toe. I'm using my mouse, drawing around here, pointing out that this is swollen, this is red, and this would be exquisitely tender. In this slide, the patient also happens to have ankle involvement, so there is redness and swelling of the ankle as well. And this is typical podagra. To throw in a couple other pictures to just to get everybody waked up, everybody awakened. But we think of gout primarily in men, but in fact it occurs in women as well. Typically in women it occurs later because of a effect of estrogen on uric acid excretion, but women develop gout as well, and they have a predilection for having it in the hands. And so here's a couple of red, hot, swollen joints of DIP of a woman with gout. I find it interesting. This is from the rheumatology slide collection. They say gout of the DIP joint simulating osteoarthritis. I trust that no one on the lecture would have trouble distinguishing this red, hot, swollen, painful joint from osteoarthritis. Here's another picture that I like to show. Gout is very inflammatory, and it really looks like cellulitis. While the crystals are in the joint, they also are outside and around the joint, and often produce a picture of cellulitis with a broad area of redness and swelling and tenderness. If this wasn't a gout lecture, and I just showed you this slide here on the left side of my screen, I suspect most of you would think of this as infection. Here's a big red swollen toe, and it even looks like we've got streaking and extension up over the dorsum of the foot. And what we see draining here might be interpreted as purulent material, but in fact, this is a crystal and this is a draining tophus. So I'd ask you, whenever you see a patient and you think this might be cellulitis, ask yourself, is there a joint in the middle of it? And if there is, consider the possibility that this could be gout. Okay, so acute gout. I showed you the MTP because that indeed is the most common initial joint to be involved. And it has the characteristic features of being very severe joint inflammation, often beginning in the middle of the night and reaching its peak in a very short time. It goes from 0 to a pain score of 15 in the matter of under 12 hours. That's really characteristic of gout. It's usually monoarticular, but as time goes on, it may be polyarticular. And while the first attacks are typically the MTP joint, it could be the other MTPs, it could be the midfoot, particularly difficult to diagnose there because there's nothing to tap. Could be the ankle, could be the knee, could be almost any joint. An observation is that we see patients who have severe peripheral neuropathy who present with gout in joints outside the foot. Suspicion that perhaps they're having attacks but being less aware of them than patients who don't have peripheral neuropathy, and so they're preventing later. So keep that in mind. If your patient has a peripheral neuropathy, they might not present initially with the classic attacks. They might present with other joints being involved. Now, the attack will subside in 3 to 10 days, even if you don't do anything about it. So the attack is self-limited. That is one of the characteristics of crystal-induced arthritis. So if you think about it, if you thought that patient actually had cellulitis and you gave them a week of antibiotics and they get better, you might never appreciate that this was really gout. Of course, urate crystals are present in the synovial fluid. There are lots of them there during the attack, but they are also there in between attacks. And hyperuricemia may or may not be present during the acute attack. It is well known that serum uric acid frequently falls at the time of an acute attack. So as 50% or more will have a normal or even a low uric acid. So if you think this might be gout and the uric acid is 4, that doesn't mean it isn't gout. It just means they're not hyperuricemic at the moment. They have to check it again at another time once the attack has been resolved. Okay, what precipitates gout? You've seen and recognized a lot of these factors. I think of gout as a really nasty player. It likes to pile on when patients are already sick. So acute illness, infections, pneumonia, ICU, osteomyelitis, following surgery. Very common for gout to appear in that post-op or immediate post-illness period. Things that can trigger it would include dehydration, as I mentioned, diuretics. Those patients, I'm sure you have many of them, they're patients with pretty severe heart failure, and every time their diuretic dose is changed, they develop an attack of gout. So those can all be precipitants. Acidosis for any reason can precipitate gout. And remember, anytime you change uric acid levels, whether you're going up or going down, you will precipitate attacks of gout. Finally, trauma is recognized as a precipitating for gout. Perhaps that's why the MTP is so common. And you may have seen this clinical scenario. The patient says, I bumped my knee on the coffee table 2 days ago. It didn't hurt at all. Now, 2 days later, it's very painful and swollen. This may be delayed trauma, but it's equally likely that this is an attack of gout triggered by the traumatic disruption of the crystals. Now, this is a slide of urate crystals. They really are much, much prettier than this, but these are negatively birefringent crystals that glow beautifully under polarized light and are really very, very characteristics. I'm not going to talk much about the biochemistry or the immunology of an attack of gout, and so you'll be thankful to know I'm not going to go through this slide, except to point out that urate crystals are extremely inflammatory. We know that they are ingested by neutrophils with release of all the neutrophil lysosomal enzymes, but they activate complement, bradykinin, synovial cells, endothelial cells. Every inflammatory pathway you can imagine can be directly activated by urate crystals. And the primary cytokines that result are TNF and IL-1, strongly pro-inflammatory cytokines. Now, an interesting question is, so the gout crystals are in the joint all the time. Why don't we have continuous gout? If the crystals are so inflammatory, why isn't gout continuous? Best answer, imperfect, is that the crystals are somehow coated or walled off by fibrous tissue or other proteins that somehow disguises them from the immune pathways. But it is surprising that gout is as intermittent as it is. The other curious thing about gout is, why does it stop? If it's so inflammatory, what makes it stop on its own without treatment? And this is an interesting study in which you take uric acid and put it in a test tube with macrophages. And what you see is, on day 1, the macrophages go nuts and start producing lots of TNF and IL-1. But by day 3, they're kind of exhausted their supply and are tired of producing these inflammatory cytokines, and they switch to producing TGF-beta. And TGF-beta is an anti-inflammatory cytokine, which effectively turns off the inflammatory process. So this inflammation stimulated by the crystals, the macrophages mature and actually turn off the inflammation. Interestingly, this maturation is inhibited by corticosteroids. So those who know what I'm going to talk about later, the rebound effect of corticosteroids, in which they treat an attack of gout, but it recurs over and over may be related to this inhibition of macrophage maturation, and in essence preventing the body from doing a more permanent turnoff of the crystal-induced inflammation. Okay, let's get back to the patients. I've got a patient, let's say the patient is in CLC. He just arrived here a few days ago from the acute unit after an acute medical illness, and they have a swollen, painful ankle. How do I know whether this is gout? Well, there's a couple of ways to think about it. What I have in front of you is the so-called acute gout rule. I put it in quotes because this is not very well validated. I think it's discussed and talked about by residents and fellows more than the data supports, but it does point out the relative value of certain risk factors in helping you come to a probability that this is gout. So if you notice, you get points for being male. That certainly increases the risk. Previous flares of a similar nature also gives you more points. Note rapid onset. If the onset is less than a day, that also gives you some points. Presence of redness. Be careful, the redness can be hard to see in very dark-skinned patients. MTP, big points for being an MTP. Notice if you had hypertension or cardiovascular disease, that actually increases the point. And if the patient has had a hyperuricemia at any time, you get more points for that. So higher than 8 points, there's a very high probability that this is gout. Less than 4, there's a low probability. In the middle is everybody else. But of course, I'm a rheumatologist, so you know the best way to make a diagnosis of gout is to identify the crystals in the joint. And I continue to advocate for that because if the crystals are there, there's no discussion. That's clearly the cause and is helpful for long-term planning. But reality is you can't always get crystals. You can't get them. You don't know how. The patient won't let you. So another simple rule that's often used is if you think the patient has an acute self-limited monoarthritis, they've had 3 or more episodes, one of them is podagra, and at some point in time they've had hyperuricemia, that combination of factors is highly specific for a diagnosis of gout as well. Okay, so let's say your patient has you believe your patient has a high risk that this is gout, or perhaps even better, you've gotten crystals and proven that it's gout. What are your treatment options? Mostly familiar drugs with one new twist here. I think the preferred treatment for acute gout, all other things considered, is high-dose NSAIDs. It's effective, it works quickly, and the patient gets very rapid pain relief. Notice I said high-dose NSAIDs. I didn't give any particular one. For some of the older clinicians, we used to talk about using indomethacin, and while indomethacin is indeed a very effective treatment for gout, it has much higher risk of morbidity, confusion, sodium retention, GI bleeding, and so I wouldn't no longer consider that to be the preferred option. So any short-acting NSAID given initially at high doses would be effective. The problem, of course, is that many of our patients are not candidates for NSAIDs because of potential renal toxicity, cardiovascular risk, or GI concerns. Now, colchicine is particularly effective if taken early. Many patients who have gout learn that if I take one colchicine pill as soon as I think I'm going to get the attack, it stops it right away. the current regimens of colchicine, which is to take 2 tablets, 1.2 milligrams, followed an hour later by 1 additional tablet, a total of 3 tablets, is just as effective as higher dose regimens that we used to use. And so there really would be no reason to give patients more than 3 tablets currently. The key here, though, is if taken early. This is going to be less effective if the patient has had the episode already for 3-4 days ongoing. Will have some benefit, but will be less effective. So unfortunately, we're often stuck with steroids as our first choice. It's okay with renal disease. We're a little less worried about GI toxicity, but the problem is it's steroids, and many of patients are diabetic and have coexisting infections. So that's a concern. And finally, as I mentioned earlier, steroids frequently result in rebound attack. This is the most common cause of a rebound rheumatology consult. Patient given steroids, attack completely gone. 2 days later, it recurs. And so this cycle of attacks recurring as soon as the steroids are stopped can be a challenge when you're treating patients with steroids for acute gout. One of the tricks there, what do you do, is if you've seen this rebound attack, is to treat them for a longer time at a lower dose. So use those low doses for perhaps another week or so to try to get them, prevent that rebound. Now notice I didn't mention anything about a steroid dose. There really is very little, surprisingly little information about high dose versus medium doses of steroids. The only published study that I know of a randomized trial was actually done by one of my colleagues, Dr. Ostrowski, who, as a fellow, started a trial comparing high dose versus medium dose, high dose meaning milligram per kilo versus a 0.5 milligram per kilo in a randomized trial for the treatment of acute gout. And it was a fairly small number of patients, but at least in her study, there was really no difference between a milligram per kilo and a 0.5 milligram per kilo. So she taught those of us who always used to use high doses that moderate doses may be just as effective in patients, and we don't need to use as high doses as we did. That being said, there are patients who simply don't respond sufficiently, particularly those with very advanced disease, polyarticular disease, who may still need doses of a milligram per kilo or even higher. One underutilized technique is intra-articular steroids. Once you're certain that this isn't infection, that works great. The problem is an injection is needed, and getting that done can sometimes be a challenge. And there are patients I've wanted to do this, and they said, you're going to put a needle into that painful joint? No, thank you. So, but that's something certainly to consider and can be very effective. The final, somewhat newer technique in patients for whom none of these other options are reasonable because of their comorbid illnesses, is to use IL-1 inhibition. There's a drug called anakyra, which is a direct IL-1 inhibitor. It was developed for rheumatoid arthritis. It doesn't work very well for RA, and it requires a daily injection, so it was not very popular, but it's an effective inhibitor of IL-1. And so a simple regimen of 100 milligrams sub-Q for 3 days actually works quite well in the treatment of acute gout. So in a hospitalized setting where you're able to get that drug fairly quickly, that's a technique that can be quite useful. The cons, of course, it's a biologic, it's expensive, and in an outpatient setting, you probably can't get it fast enough to be useful. Okay, so the patient has had one attack of gout. You've treated it effectively. What happens now? Well, what I've listed here is the natural history of gout, although there's some variability in the time frames. This is the pace and the progression of gout untreated. So in the beginning, patients have rare intermittent attacks. It might be every couple of years, or maybe more frequent than that, but it's a rare self-limited attack with no symptoms in between. As time goes on, the attacks become more frequent. And as they become more frequent, they also become more difficult to treat, involve atypical joints, and are polyarticular. So by atypical joints, in addition to the ones I've mentioned earlier, it can be joints like the shoulder or the wrist, for example. Some of the more unusual joints that have been well described would include the facet joints of the spine. Typically, these patients present with severe excruciating back pain. Imaging suggests an infection, and when the joint is aspirated, crystals are found instead. The sacroiliac joint, crystals have been found there. And I have to say the most unusual joint I personally have found urate crystals is the acromioclavicular joint. So keep it in mind in all sorts of atypical joints in patients who have a long-standing history of gout. Untreated over time, patients will develop tophi. In at least one very large older series, by 15 years, half of the patients had tophaceous deposits. Where do you find them? Well, in the textbooks, you find them in the ears. My experience is they're not actually very common there. They're most common in the elbow, but they also can occur over bony prominences. The feet, the fingers would be typical areas. And if the hyperuricemia is not treated at this point, over a long time, patients can develop very severe tophaceous deposits and disease. Here's a couple of pictures. Here's a small tophus over a finger joint. It typically has this sort of yellowish discoloration. Here's an olecranon bursa. This may look and feel something like rheumatoid nodule. So if you have any concerns, it's really quite easy to put a needle in, draw some fluid, and identify the presence of crystals there. I mentioned joint inflammation. You also can get gout in these bursa. So it's not unusual for a patient with a tophi in his elbow or a tophi over the knee to develop a acute inflammatory episode of gout related to bursal inflammation. And this is a patient with a very severe tophaceous gout. Fortunately, we don't see very much of this anymore, and this really should not be happening. Okay, so who needs hypouricemic therapy? The patient who has their first attack? The answer to that is no. The recommendations are that a single attack in most clinical settings would not be an indication for hypouricemic therapy. The rationale there is that while that individual is definitely at an increased risk of having a second attack, it may be many years. In one fairly large study, patients with uric acid, patients with a single attack of gout, only 25% of them had the second attack at 5 years. So the indication with a single attack would be obviously educate the patient, make changes in diet, which we'll talk about in a minute, but not to start hypouricemic therapy. Now, there may be exceptions to this. Patients who have significant renal insufficiency, who are at very high risk, you might want to consider treating them sooner. But most initial attacks, educate, advise, watch, and wait and see. So who does need hypouricemic therapy? Frequent attacks, one very recent guideline suggests 2 attacks in a year, but obviously that's going to depend on the individual patient. How fast are they occurring? 2 attacks over 10 years is not the same as 2 attacks in the last 3 months. Everyone would agree that patients with erosions or patients with tophi should receive treatment. And of course, patients with renal stones from uric acid should also be treated. Okay, your goal of treatment is to get the uric acid under 6. There's good evidence that goal-directed therapy improves long-term outcome. Some data is suggesting that patients have tophi, you might look for an even lower level with the uric acid less than 5, but everybody agrees that your target should be to get the uric acid less than 6. The #1 preferred treatment is allopurinol. This is a xanthine oxidase inhibitor, so that you don't obviously don't produce uric acid. Historically, we've started patients at high doses, or I shouldn't say standard doses, 300 milligrams. Current evidence suggests, though, that a low dose titrating up will be 2 benefits. One is not everybody will need the higher dose, and there'll be a lower risk of precipitating flares with the low dose. So the current recommendations are 100 milligrams per day. Check the uric acid at least 2 to 3 weeks after starting the drug, and titrate up until you reach your goal of a uric acid less than 6. A question that's come up for a long time is, can I start allopurinol or any hypouricemic drug during an acute attack? Historically, we've taught no, you shouldn't do that. But in fact, there's really almost no evidence to that black pearl. And at least one study has shown that an acute attack is not lengthened or more difficult to treat if you start hypouricemic therapy concomitant with the treatment of the acute attack. So the current recommendations are, if there's an indication to start hypouricemic therapy, just go ahead and start it right away. It leads to less confusion. As I mentioned, for patients with normal renal function, 100 milligrams per day. If the patient does have renal disease, start at even lower doses, and I'd say if the GFR is less than 30, would start at 50 milligrams per day. Now, allopurinol is extremely well tolerated, with probably rashes being the most common side effect, but there is a very rare, potentially fatal side effect, a hypersensitivity reaction. And these are patients who develop extensive skin necrosis in the setting of bone marrow suppression, acute renal failure, and an acute hepatitis. It's sort of a multi-organ system hypersensitivity reaction. And this reaction is more common in patients who have an HLA B5801, which, yes, that is something you can order and measure. And this HLA type is more common in the Han Chinese, Koreans, and Thai population. So it's been recommended for several years that this population, you should test for HLA B5801 if you're considering starting allopurinol. Just in the last several months, guidelines recommendations also added African Americans for screening for HLA B5801. Although it's not as common in that population as it is in the Asian populations I mentioned, it is higher than the non-African American population in the U.S. And so, given the severity of the reaction, we'd recommend that you screen before starting allopurinol in African Americans as well. A second xanthine oxidase inhibitor, something called febuxostat, was released about 5 or 6 years ago. It has the same effect, uses a different mechanism. It does not cross-react with allopurinol, so it is nice to have a second alternative for those patients who do have a reaction to allopurinol. Unfortunately, it has been shown in a observational studies to have an increased cardiovascular risk. Now, that seems paradoxical given what I talked about earlier with hyperuricemia potentially as a risk factor. But this was seen in the phase 3 clinical trials as well as in the post-marketing observational trials. So for that reason, febuxostat would really be a second-line drug behind allopurinol. A couple other options for you. Probenecid. Probenecid works by increasing urinary excretion. We don't use that very much, which is unfortunate perhaps because it actually is a very effective drug. The problem is it is not for overproducers. Historically, we've talked about doing 24-hour urines to measure urinary uric acid in patients who were considering probenecid. Recent guidelines have eliminated that from the recommendation, but certainly anybody who has a history of kidney stones would not consider probenecid. Also remember, probenecid its effect is inhibited by renal failure, aspirin diuretics, which is many of our gout patients. This is not Leningrad. This is Lesinurud. Spell check doesn't always get you out of trouble. This is a recently approved drug, which does inhibit URAT1, increases urate excretion, and it's designed to be used in addition to xanthine oxidase inhibitors. So a patient who's on allopurinol diseases, uric acid is still not controlled at effective maximum doses. That would be a consideration. And then for those very rare patients who have extremely severe disease, we do have uricase peptidoglycase 2 preparations. These are given as an IV. They are very potent, very effective, but significant toxicity. And we do on occasion use these for patients with severe disease. Okay, if you remember, I mentioned earlier that changing levels of serum uric acid precipitate gout. So if I'm giving the patient a hypouricemic drug, I have a considerable chance of inducing a flare. So some studies as many as 40% at 1 month, 20% at 2 months, and even 10% of additional flares at 3 to 6 months. So anytime you're going to give a patient a new prescription for a hypouricemic drug, you should consider giving them prophylactic therapy for 6 to 12 months, some would say 3 to 6 months, depending on their severity of their disease. Now, what are your choices? We typically use low-dose colchicine, 0.6 milligrams, once a day or every other day. Be careful with low-dose colchicine, however. Patients with renal, even mild degrees of renal insufficiency, patients with concomitant statin therapy are at risk for developing a myopathy, which can be quite severe. So be careful in patients, particularly those patients with chronic kidney disease. NSAIDs, if the patient is a candidate for NSAIDs, or if they're already taking daily NSAIDs for another arthritic problem, can be helpful. And if you're really stuck, even low doses of steroids, 5 milligrams, may be sufficient to suppress attacks for the first 6 months or so of hypouricemic therapy. And don't forget to save everybody phone calls and the patient a trip to the ER to tell them what to do if they have another attack. Many of these patients know exactly what what the attack is like, can predict it, and make sure that they are well prepared with medicines on their shelves to treat it. So a phone call instead of an ER visit will treat their disease. Gout and diet. So diet really has a very small effect compared to what we can do with drugs. So there's a relative downplaying of diet on gout, unless, of course, you want to use it to get your patient to lose weight, since weight loss clearly decreases serum uric acid. And while they're having those severe attacks of gout, you probably have their attention. The key dietary factors are red meat, shellfish, and high fructose corn syrup. High fructose corn syrup is the common sweetener in juices, sports drinks, and most sweets that are purchased. Of many patients who don't recognize that the pop they're drinking, the orange juice or the Gatorade actually has substantial amounts of fructose in it, and that actually can trigger gout. Purine-rich vegetables have no effect. So despite what they might find on Google, they have no effect on your serum uric acid. So this is not an excuse to stop eating your vegetables. And there's some data that low-fat dairy foods actually will decrease serum uric acid. Alcohol, of course, there's another reason to convince patients to reduce alcohol. Beer is the worst, hard liquor less, and if they must, wine has the least effect on serum uric acid. Okay, the last slide is just to talk about renal complications. If we go back to the very first slide I showed you about the gentleman with the attack of gout, he probably developed tophi over many years, and when he died, he would very likely die of renal failure. At an autopsy, what we would find in the kidneys is that there would be extensive tophaceous deposits. So don't forget that hyperuricemia affects the kidneys as well, and it can do it in 3 ways. The first is by causing renal stones. Patients can have uric acid stones. They also can have hyperuricosuriac can be a nidus for calcium stones. So there may be reasons for patients to be on allopurinol even if they're having calcium stones. The second is the chronic urate nephropathy I just referred to. This is chronic deposition of urate throughout the interstitium and in the of the kidneys. You might say, well, gee, should we be treating patients' elevated uric acid to prevent renal failure? The answer to that is no. Although we know that patients who have tophaceous gout have tophaceous kidneys, if you'll allow me to use that term. Patients with asymptomatic or non-tophaceous gout have treated with allopurinol in some controlled as well as observational trials have not shown any preservation of renal function with the use of a drug like allopurinol. So right now there is no reason to treat asymptomatic hyperuricemia for the prevention of kidney disease, or to use chronic urate nephropathy as a reason in the absence of gout to treat your patients. Finally, patients with very severe elevations of uric acid, as in the setting of trauma or leukemia, can develop an acute urate nephropathy. The fractional excretion of urate will be greater than 1 under those circumstances. The main your measure that urate is contributing to the renal failure, acute renal failure in this patient. Okay, I think I will stop there. I've used up most of the hour, but we've got a few minutes and I'm available for questions. Let me get rid of my screen and let's see. Okay, I was able to do that. Looks like we've got some questions already. Okay, first, questions I see. I can, unfortunately, only see part of it. What is your take on reducing the dose and or stopping allopurinol in patients without flare for several years? Unfortunately, I can't see the last part of your question. So recommendations in a patient who's begun on allopurinol, that the treatment should be continued indefinitely. There is nothing to recommend that we should stop the treatment. Now, dose adjustment, I really don't have any data to say one way or another about reducing the dose. I think if for those patients in whom we started low and titrated them up, we do find that they end up on lower doses. What to do with a patient who's on 300 because I started them on 300 milligrams of allopurinol 15 years ago. I don't really think we have any data to tell us what to do in that situation. If we think about cost, it's relatively low. If we think about toxicity, that patient is no longer at risk for hypersensitivity reaction, so that I'm not sure there's a good stimulus to try and reduce the dose in that patient. Okay, next question, Dr. Gorbian, who's a fan of using 24-hour urine collection. Again, I can't read the whole question, but a fan of using a 24-hour urine to separate. I think you're saying the high producers from the under excretors.
Do you want me to read the other part?
Yeah, can you read the rest of it? Thank you.
Yeah, I've been a fan of using 24-hour urine collection to separate on high versus low excretors. Is there a role for a 24-hour urine collection?
Yeah, so current recommendations are that it's not worth the trouble. So currently they are really recommending against taking the effort to do that. We recommend allopurinol as the first line drug for everyone. So probably not much reason to do that unless the patient has kidney stones and we need to understand what's contributing to their renal stones. Okay, Marty, then how do you decide on probenecid? So I think if our first line treatment is to inhibit xanthine oxidase, so I would use allopurinol first. If the patient had a rash to allopurinol, I would stop the drug and use febuxostat instead, an alternate xanthine oxidase inhibitor. If the patient had a reaction to that, I haven't seen that yet, then I would probably consider probenecid in that patient. And I think the chance of them being an overproducer is less than 10%. So no one's going to fault you, Dr. Gorbian, for doing the 24-hour urine, but I think in the past we probably did too many of them. Okay, here. Second question, what would you recommend for prophylaxis for a 96-year-old patient starting urate lowering therapy with allopurinol on statin and severe? You're going to have to finish.
Severe diarrhea with 3 doses of colchicine.
Yeah, okay. So you've got a couple of options. One would to go with a really, really low dose of colchicine. You could use something as low as 0.3 milligrams every other day. So that's a really low dose, and I have used that in patients with some success. 96, I can't imagine her kidneys are good. I can't imagine NSAIDs would be a great idea, so I wouldn't go there. You could weigh using something like 5 milligrams of prednisone as the other option. Of course, the final option would be, say, to recognize that it's preferred to use a prophylactic drug, but the risk of all of them outweighs the risk of having an attack. Okay, any other question? Okay, I'm just going to add that in June of 2020, the American College of Rheumatology published guidelines for the management of gout. I'll send that link to the geriatric office. You all might want to have that article handy for you, and maybe they can forward that out, and you can have it on hand if you want to review that. So, thanks for inviting me. I've enjoyed talking to you all. I do like it better in person, but we'll see you all in the hallway.